going to be straightforward. I'm not going to beat around the bush and give you the content you need to know. We're taking the first one, Conn and Pheochromocytoma. The key thing is you're supposed to know is they are coming from the adrenal gland. Adrenal gland has two layers. This is the cortex, okay, and this is the medulla. Conn's disease is from a tumor in the cortex, right? And then medulla, the pheochromocytoma is a tumor in the medulla. That is the difference. So both of them as a problem related to the adrenal gland. So that's the key thing you're supposed to know. What is the difference? The difference is Conn's is due to aldosterone. So aldosterone secreting tumor, right? It's aldosterone that is secreting, it's a tumor that is secreting aldosterone. Therefore, and that is coming from the cortex of the adrenal gland, right? That's all. It's adrenal tumor that is secreting what? Aldosterone. And all you need to know is that what is aldosterone? That's all. You don't need to do anything. Aldosterone loves sodium. If you love sodium, you're going to love water, right? And when you love water, sometimes you have to love glucose. So this can also increase your glucose. But what does he hate? He hates what? Potassium. Whenever you love sodium, you're going to hate potassium. And this is what happened. So you have high sodium water, that means fluid retention. Then you can have hyperglycemia, and then you have low potassium. What else is going to happen? As you begin to lose your potassium, your body will try to compensate and therefore reabsorb the potassium and get rid of your acid. So you lose acid. And when you lose acid, you become what? Metabolic alkalosis. So these are findings related to what? Conn's disease. So you have to know that high sodium, high water, low potassium, fluid retention, and what? Metabolic alkalosis. These are signs and symptoms related to this problem. Therefore, what do you think the patient's signs and symptoms will be related? Signs and symptoms. Well, if you have sodium retention, right? If you have sodium retention, what is going to happen? Hypertension. That's all. They're going to have hypertension. They're going to have headache, and they're going to have fluid retention. These are the signs and symptoms. Therefore, how do you want to treat them? Think about it. If you want to treat somebody whose potassium is low, well, eat some banana or anything that will increase your potassium, like avocado, like according fast, like fish, avocado, strawberry, and tomatoes. That's what it is. Fish, avocado, strawberry, and tomatoes have a very high potassium content, and therefore when you take them, yeah, your potassium is going to increase. What else do you want to do? You can give them case-sparing medication, especially spironolactone. What does it do? It blocks aldosterone, and therefore it's going to increase the potassium. So you block aldosterone. It's case-sparing to increase potassium. Remember, there's other medication that can do that. Really no. It's also do that. Try Trigeminal also potassium sparing. So this is the treatment for Conn's disease. There's no questions they're going to ask you that you don't see it on the board. Straightforward, aldosterone secreting, all the signs and symptoms you're supposed to know, and what is the treatment. That's all. What other thing you would tell them? They retain avoid sodium, therefore low salt diet. The next one is pheochromocytoma. I told you it's the adrenal gland, the medulla. The medulla is going to secrete monoamines. Monoamines are norepinephrine, epinephrine, dopamine, serotonin, right? And these are what, if I inject epinephrine in you right now, you know what is you're going to do. They are all monoamines, right? So if they are all monoamines, what kind of signs and symptoms you're going to show? Monoamines usually show signs and symptoms of what? Hyper symptoms, right? The symptoms usually show hyper symptoms because they're going to speed things up. They're going to speed things up. If you're going to speed things up, how do you recognize pheochromocytoma? I call it the 5H. So know the 5H, right? They have what? Hyper metabolism because they're speeding things up. If you have hypermetabolism, you're going to sweat. So hyperhidrosis, they sweaty, right? Therefore, what? When they happen, if you increase your metabolism, that means you need some glucose to be able to do that. So they have hyperglycemia. So hyperglycemia is very common in these patients. Well, the most number one symptoms is headache, and this headache is episodic headache, right? And that's one of the things you have to pay attention to about them. And the last one is hypertension because these are monoamine. So these are the 5H you're supposed to know for chromocytoma. So this is classic signs and symptoms that you have to know for them. He has hypertension, low salt diet. His patient is having hyper symptoms. What do you want to do? Low stimuli, environment as much as possible. It's like a patient with maniac episode. Hey, yeah, low stimuli, right? What do you think? They have really high metabolic activity going on. So they need high calorie, right? High protein diet to compensate for the high metabolism that is going to have it, right? They should avoid monoamines as much as possible. So this is the things you teach them, and these are the things you have to expect. You will see in the question that they're going to ask you, right? And then most of the time they will need surgery. So what is the medication? Because of the high metabolic rate and hypertension and all these things, they need fluid. They really, really dry. So fluid is the management. Give them a lot of fluid, followed by alpha blocker. Alpha blocker is phenoxybenzapine or phentolamine. These are the medication you will use before you do any surgery. Then beta blocker. So you don't give them beta blocker until you have given them alpha blocker in addition to fluid before you do anything with these patients. You cannot do surgery unless you've done all the things that I've told you. Benzo, benzo, ben, phenoxybenzapine or phentolamine, then you give them beta blocker. So this is the management of this problem. Pheochromocytoma is a straightforward problem. They're not going to ask you anything that you don't see. So this is the way they will ask you the question related to that. Cystic fibrosis. Straightforward, right? This is a problem related to sodium chloride channel. Okay, they have a genetic defect that they cannot control their sodium chloride channel, and this is autosomal recessive. That means both parents are involved. You got to get one from your mother, you got to get one from your father, right? And then about 25% of the children will be affected. So 1/4 of them will be affected. What is the problem? It's going to be cause of lack of a sodium chloride channel, which is going to hold on to water. They cannot hold on to water, cannot. So they cannot do that. Because of that, secretions are all thick. They are all thick. And two organs that are affected is your lung. This is number one that is affected. Therefore, lung secretion are very thick, mucoid, and they can't get rid of the secretion. So you need something to break down the secretion. That's why they use mucolytic, something that will break down the secretion, like acetylcysteine, right? This is why we give them acetylcysteine to help with the secretion, and then they can get rid of it, right? So what is your management? How can you help with this patient get rid of their secretion? Well, we do chest physiotherapy. Don't worry. Sometimes they don't use that word. Be careful. They will use postural drainage. It's the same thing. When do you do this problem? When do you do that? Well, because we're placing you on your face and we're banging your chest from the back. No, we're banging your back and your face is on the table or in the prone position. There is a risk of aspiration. Therefore, what are you going to do? Aspiration, right? We want to prevent aspiration. Therefore, we do it 1 hour before you eat or 2 hours after eating. So this is the key you have to teach the patient or the family to know, or the nurse, this is the thing we have to do that. So that's the thing. Expected finding. This is classic. This is what you expect. The secretion is going to be what? Thick. They're going to have recurrent infection. They may have some fever. It's okay. Don't worry about it. Okay. Recurrent infection, all these things, it's expected finding. It's not a priority that is supposed to know. It's not a priority. Pay attention. The other thing too is we want them to exercise to improve their lung function. At the same time, I want you to, when you exercise, avoid hot water, okay, and have some soft tap with you all the time. This is the pulmonary function of cystic fibrosis, and this is classic, something that you should expect they're going to ask you. Now, if you come to the GI symptoms, hey, the same thing. The biggest one is the pancreas. The pancreas cannot secrete its content because it's too thick. In the process, well, major signs and symptoms is what? Deficiency of ADK, that's vitamins. These need pancreatic secretion to help them absorb. They are called fat-soluble vitamins, but they will be lacking because there's no pancreatic enzyme. Therefore, provide them these vitamins. Provide them the vitamins. What do they need? Pancreatic enzyme. Therefore, give it to them. They call it pancrealipase. So they need pancrealipase to be able to eat. When you give it to them, when they're eating or when they have snacks, you can even sprinkle it on their food, and it's good. So those are the things you have to pay attention to regarding these conditions. Remember the same thing. Give them salt tabs. Make sure they're drinking a lot of water to help with that. Is a specific finding expected in terms of the GI that they will try to trap you. These people, their stool is going to be fatty, right? It's going to be large. It's going to be voluminous. These are bars where they will use. It's going to be, it's very thick um, and it's sluggish. Because of this, you have to give them enema to get rid of it. So stool is going to be fatty, large, voluminous, and some enema to help with getting rid of the stool easily as much as possible. Okay, There's other thing too that you have to do because of they cannot absorb any of their nutrients. They need large, high calorie, high protein, and high fatty diet. Not high carbohydrate. Because the pancreas is not working, okay, no high carbs. So I know high glucose or high carbohydrate. Because the glucose is not working, the pancreas is not working. If you give them too much carbohydrate, they get diabetes. So you want to prevent diabetes as much as possible in these people. Okay, so those are the things you have to pay attention. They will need a lot of help. So this is the patient that will need multidisciplinary care involving case manager, even social worker, respiratory, everybody is involved to take care of this patient. So that's that information. I told you straightforward. You got to listen carefully, right? PKU, Phenylketonuria, right? PKU. This is one of the newborn diseases that we check. It's part of the newborn screening that we do. Usually we do it 24 hours to 7 days, right? That's when we do it. As soon as you're born, 24 hours later, we do it in 7 days. We checking for a deficiency in this protein metabolism, phenylalanine. They cannot metabolize defect in metabolism of this protein. And so that's what we call PKU. What is the problem? Since they cannot metabolize it, there's another way they can ask you a question. You see, it's done 24 hours after birth. If you do it before 24 hours, then you got to wait. They have to recheck it again 2 weeks later. But usually we do it 24 hours after birth. So it's part of the screening method. How would the patient present if they lack metabolism of phenylalanine protein? What do you see? You see growth retardation. You see disability. And then you're going to see microcephaly. The head is going to be like small. And this may be a case study. What is going to be happening? Mommy said, I had a baby, feeding the baby, and every time I give the baby protein, it gets sick. That is your key. This is your key. Every time I feed the baby gets sick. So that's your key idea to know that, oh, something is not right, right? Something is not right. So the mommy will bring the kids to the hospital and then we'll figure out, oh, this may be the symptoms. What is the treatment after the test and they ship that they have a deficiency in the phenylalanine, the treatment, then don't eat too much protein, right? Right. So low phenylalanine diet, that's the treatment. And this is for life. You can't change it. This is one of the teaching you provide the patient. Which food they should avoid? Well, meat has a lot of protein in it. Dairy product has a lot of protein in it, right? Eggs, they cannot eat it, right? Neutral sweets, that's a lot of protein. Even beans, they cannot eat it. What can they eat? Okay, to eat what? Well, they can eat special like milk, like phenolac, lophenolac, right? That's the most common. Or you can, if you see a question, they say phenylalanine free diet. That's okay. You can pick it, but there's no phenylalanine in free diet. Some have very low amount, and so those are the common one you see in the question. But this is the way I want you to think about this situation as much as possible. That's the content right there. Simple, straightforward for you to think about and then analyze it. So when you see a question like that, this is what you see. This is all you need to know. Okay. Now, my favorite, PAD versus chronic venous disease. Well, I don't know what to tell you, but this is classic cerebrovascular disease. So if you draw your heart like that, if this is your heart, you have your vessel that comes along. There's three of them. And one come down. This is descending aorta. You go to the abdomen, then you go to your leg. There's certain things that can affect it. Hypertension will make this develop plaques, or it get thicker, right? Fat will make the inside lumen get thicker, plaques, calcification. All those things are bad problem that can make the vessel thick and it prevent blood flow. In the process, blood go in the dependent position. So if he doesn't have the choice to get down, it's a problem. So this is all you need to know about peripheral vascular disease. It's a flow problem. So if we have a flow problem and blood flow in the dependent position, what is your risk factors? Well, I've listed them. Hypertension, right? Diabetes. Age can cause calcification of the vessel. Smoking damage the vessel. Hyperlipidemia causes plaques. So these are the common cause of peripheral arterial disease. It's the same thing that causes cerebral vascular disease because it's a stroke. The same thing that will do that. So know these 5 factors. But then, how would they present? Well, presentation is classic. You get claudication. What do we call it? I call it they have heart attack of their calf. It's a demand ischemia. As you walk, you're asking for more blood, but blood flow in the dependent position. But the vessel is completely getting occluded. What is going to happen? Less blood flow, and you get into trouble. So the main idea of PAD is less blood flow. If you know that, every signs and symptoms, think about it that way. Less blood flow. If there's less blood flow, then what is going to happen? Your leg is going to be cold, right? If less blood flow in your legs, they're not going to be, they'll be hairless. They grow. Some of the hair follicles need to grow every 3 days. If there's none, they're not going to grow, right? Your leg is going to die. You get ulcers in your toe. Your toe is the one that is going to suffer, right? The skin became a trophic skin. You don't have to memorize them. You can make it up, right? Your nail is supposed to grow every time. If it can, the old nail stay there and it become thickened. You see what will happen? The pulses will decrease. And sensation, so sensation is decreased together with your pulses. Your capillary refill is going to be greater than 3 seconds. That's bad. Okay. Your toe is going to die, gangrene. That is all expected finding. You should not be worried about it. These are the things I want you to think about, and you can make it up as you go, right? So those are the things I want you to think about. Then, what is the teaching? Well, blood flow in the dependent position. If they elevate their leg, the leg will become polar, white. But if they put it in a dependent position, it become rubber. So this is what we call dependent polar, and then elevated polar in dependent position, it become red. So your teaching is dangle your feet. I want you to dangle your feet. Don't elevate it, don't or cross it. No, don't cross it. Keep it in the dependent position as much as possible. So those are the things you have to pay attention to when they ask you questions. Those are the things you intervene. What is the treatment? They need aspirin. Aspirin is antiplatelet. It's going to prevent embolization because it stabilizes the plaque. So this is going to stabilize the plaque to prevent platelet aggregation of that. Another anti-platelet is pentosyphilin. So Don't forget this medication too. This is antiplatelet. Of course, they have to treat the medical problem that causes everything, right? All the medical problem that causes it. So they have to treat the hypertension, diabetes, their hyperlipidemia. They cannot do anything about their age, right? But they need to stop smoking. But if they give you a question and they said, what is number one? Number one treatment is walking program. Walk until you have pain. Talk a little bit. And walk past that area. This will lead to neovascularization. So they're going to make new vessels, right? You're going to make new vessels. So this is something you have to tell the patient to make new vessels. That's the teaching you provide them. That's peripheral arterial disease. Okay. The venous disease is the same thing, but in the opposite direction. This is the vein. Okay. The vein usually blood flow in one direction, it goes up. When the vein get affected from DVT and other things, the vein start to point down, the valve. So you have a reflux. So blood basically stay in your leg. Instead of going up, you have blood sitting here like that. Blood is no more going up, it is staying. And that is the signs and symptoms you can make up of it. So chronic venous disease, okay, due to like excessive blood in your leg or just a reflux, right? So blood is just sitting there, it's not going anywhere. What is the risk factor? If you stand for a long time, for long standing, if you have DVT, if you're pregnant, or you take anticoagulation, right? Those are the things that, or oral contraception, sorry, oral contraception, these will cause DVT and it puts you at risk for chronic venous disease. Know these things, prolonged standing DVT, pregnancy, and like in nurses, right, who stand for a long time, who have this problem. So what do you expect? Blood is sitting there, blood is warm, your feet so warm, right? Your pulse is normal. Your sensation is going to be normal. Your capillary refill is going to be less than 30 seconds. Yeah, those are all normal. Blood, when it sits there for a long time, it will erode the skin and it will create ulcers above the ankle. But these ulcers, they are beefy red. Unlike the peripheral arterial disease, the ulcers are black and they like pale looking. So this one, they are beefy red, right? Then what are you going to see? You're going to see that the blood, you can feel it under the skin, and the blood vessels, when the red cells break down, the hemosiderin in the hemoglobin get deposited on the skin, and you have browning and pigmentation. So this is all the things you see in this situation. And the skin, because of the amount of blood, you see edema, or it's very thick. It's not atrophic, right? So these are some of the things I want you to think. I'm not going to give you everything, but I'll give you enough to answer any questions related to this difference between them. So just pay attention to that, right? Pay attention to that. What do you expect, okay, in terms of treatment? If the standing for a long time make the leg have this problem, then avoid prolonged standing. And therefore, these people, elevation is good. Elevate leg. Don't put it in a dependent position. So I want you to elevate it as much as possible. And wear compression stocking. The teaching is wear it before you get out of bed. Because then when you get out of bed without wearing it, blood is already gone down. It will take a while to push it up. But before you get up, you already have it on. Hey, there's no need. You don't have to worry. So that would take care of a lot of problem for you. So this is the some of the things I want you to pay attention. And this is all you need to know: peripheral arterial disease and chronic venous insufficiency. Trust me, they have nothing to ask you that I've not explained. Even if they give you a case, you'll be able to make it up. Promise you, if you watch this video, that's what you get. Next one, post-surgical complication. Where somebody had surgery, what should you worry about? They always ask you, patient had surgery, what should you worry about? Well, there's a bunch of things you need to worry. Airway, bleeding, infection, complication related to that specific surgery, right? You have to worry about DVT. Each of them, you got to pay attention. For the airway, they will trap you, okay? So airway, of course, you need to provide them incentive spirometer to use it, right? Getting out of bed is also good. Out of bed and walk is also good. Improve their lung function. But look, they will tell you patient has decreased breath sound at long basis as post-op day one. This is normal. This is what we call athleticism. Don't freak out or anything like that. This is normal. So when they give you that, somebody has surgery and they have decreased breath sound bilaterally at long basis, they have to use that word. That's athleticism. That's normal. Okay? They may have low-grade fever, 101. It's okay. Don't worry about it. Their white count may be 11 or 12,000. It's okay. Don't worry about it. It's all normal post-op, right? But after post-op day one, yeah, you got to worry. For the wound, yeah, check the wound, okay? For the breathing, look for signs of breathing, right? Hypotension, tachycardia. Depending on what kind of surgery they have, you have to look for Kelly signs, Brayton sign, or tachycardia. So it depends, right? Especially if they have cardiac catheterization. So depending on what kind of surgery they have, you may have to figure out what you need to look for bleeding, right? So it's specific related to each of them. For DVT, you just get them out of bed to chair and ambulate them. If they need anticoagulation, give it to them. And that's all. Now, appendicitis. Look, when it comes to GI pathology, it's location. So this is your small bowel, your appendix is here like that. And then this is your colon coming down. This appendix is here. So if you draw the individual, and this is the belly button, from here to here, this is what we call McBurney's point. So they usually going to have pain in the right lower quadrant, which is what McBurney's point, which is 2/3 from the anterior superior iliac spine and the umbilicus. That's number one, right? They're going to have fever. It's an ITS, look like ITS. So they're going to have fever. Your white count is going to be elevated. It's normal. They may have nausea and vomit. They may have tachycardia, so heart rate up. All this is expected. Don't worry about it. Okay, expected finding. Appendicitis with white count of 20,000. This can be 20,000. Don't worry about it. You have fever, 101.5. Don't worry, because I expect all these signs and symptoms. And it's going to be on the right lower quadrant. It's not going to be left. It's not going to be right upper quadrant. It's going to be that. So what is your treatment? Every GI symptoms when you have ITS and they have pain, they themselves will not want to eat. So the patient already MPO. If you MPO, you get IV fluid. If you MPO to prevent gastric ulceration, you get PPI. Because you may vomit, you need antiemetic, right? Because you have IDs, we give you antibiotic. You see what I've done? Management, right? And you don't need blood, depending on the condition. This is what you get. It's okay. So treatment, and then because it's an IDs, pain management. You can give this patient pain. There's nothing wrong with it. Treatment, they may need surgery. The surgery is laparoscopic appendectomy, removal of your appendix. They go home same day, or following day. But you have to teach them that no, they can shower, it's okay, but no bath for 6 weeks. They can resume activities as correlated. There's no need to scrub the wound. They can just pad dry it as much as possible. No, nothing on the wound. There is no staples, anything like that. They usually have glue, thermobond on top of the wound, which will come out like 3-4 weeks later. What is your priority? If the patient have frank peritonitis, so you have to know what is peritonitis. They have like guarding, rebounding, or they have diffused abdominal pain. That's peritonitis, right? That's B-sharp moment. This is B-sharp moment. They're showing you that they're not doing well. Guarding, rebound tenderness, diffused abdominal pain. Yeah. 10 out of 10 pain is not enough. You have to show me signs and symptoms of peritonitis. The other condition that is your priority is look at the word sudden cessation of right lower quadrant pain. So if all of a sudden right upper quadrant is completely gone, then this is a problem. That is your priority. But apart from that, appendicitis is not the problem. Okay, so that's the first one. Diverticulitis is the same thing. But here, this is where you have the problem is the diverticulum here. It's a pocket, outparting of the colon. And these can get inflamed. And then you go into the rectum. This go into the rectum. So for diverticulitis, it's just the inflammation of the diverticulum. But the diverticulum is not infection. The lung is not infection. Not infection. The diverticulum. It's just the outpouching of the colon. In order to prevent that, fiber diet, hydration, avoid straining, and exercise. Moderate exercise is good, which is 30 minutes, 3 times a day. Hydration, they need like 2 to 3 liters of water a day. So this is what you teach them to prevent the diverticulum from getting diverticulitis. When it get inflamed, it becomes diverticulitis. That's an itis, infection, you see itis. Therefore, I expect fever. I expect white count to be elevated. Heart rate can go up, right? They have pain. But pain is going to be left lower quadrant pain because it's on the left side. It cannot be on the right side. So that is the key. They may have nausea and vomit, right? So these are signs and symptoms that you may expect. Treatment, we talked about it. They're going to be NPO. They get an IV fluid, right? They get pain management. They get antibiotic because it's infection, right? They can get antiemetic. If they're vomiting, they get PPI, right? So these are all what is suspected. What is the traps related to this? Because there's inflammation of the colon, nothing go below the rectum. So no enema, no suppository, okay, and no colonoscopy or sigmoidoscopy because it's going to cause perforation. The treatment usually they don't need no surgery most of the time. This is going to resolve with just keeping them MPO and IV fluid. After that, you start with clear liquid. Then you go to low fiber for like 2 to 3 weeks, not right away, 2 to 3 weeks. You don't eat high fiber right away. Then high fiber. Okay, and that is how you can treat this problem. Okay. Now, the pancreas sits right in the middle here. Pancreas sits here behind the stomach, like that. And its location is mid-epigastric. So the treatment, the condition, what you're going to see when they give you the pancreas question, they're going to be mid-epigastric pain. Most of the time, it's an alcoholic patient, or they have gallstone, cholelithiasis. Those are the most common cause of that, right? How would the individual present mid-epigastric pain? They most likely will have nausea or they will vomit. They will have abdominal distension because of where the pancreas is located, and they may have ileus, like obstruction, sinus symptoms. These people may need NG tube. They are the one that will need NG tube. But these are the signs and symptoms that is common. They may have fever, okay, they may have white count, their heart rate may go up, all these things is expected. Your treatment, or what do I expect, is this. Don't freak out. They may have fever, white count is up, amylase, and lipase can be 1 million. Don't worry about it. This is expected. If amylase and lipase is 1 million, it's an expected finding. Don't worry about it. Okay. The treatment is put them in the fetal position. This is the best. On their left side in the fetal position, you open the back because the pancreas is towards the back. So you improve the back and then it helps with the pain, right? They will need a lot of IV fluid, a lot of it. So because of that, you have to watch for their respiratory status, right? They may need NG tube, they may need PPI, and they need antiemetic, they need pain medication. Everybody get pain medication. Okay, and then they don't need antibiotic unless they have infection. So no antibiotic unless there's abscess somewhere. So you don't need antibiotic like that. And then you wait. Okay, when you check their lab, their glucose will be high, their calcium will be low because this is getting chewed by the pancreas, getting into trouble. Because of the pancreas that is dying, and then it suck all the calcium out of the blood. So we call it saponification. So low calcium is classic for this problem. Okay, what is your priority? As soon as they start having pulmonary issue from the fluid, so mostly ARDS, acute respiratory distress, this is your priority. Secondly, you can have bleeding issue. The bleeding, because the pancreas is here, it can bleed, and then they will have bleeding near the belly button here. They have bleeding in the flank. So those are the things you have to, that's your priority. So bleeding in the flank. So which which we will call curling sign and gray tenor sign. These are bleeding problems. So watch for respiratory status and a bleeding problem for pancreatitis. Remember, these people, they are at risk of having diabetes. So you got to make sure your glucose is getting controlled. That's those two information that you should know. 3 things put together as much as possible. Okay, we talked about this already, so let me make it brief. Peritonitis. These are key. When you hear it, just because you have 9 out of 10 pain, 10 out of 10 in your abdomen, it's not enough for me to tell you that you have peritonitis. How would I know you have peritonitis? You have abdominal. These are your weights. It's called B-sharp weights. You should check Adapter NCLEX for prioritization on B-sharp. Abdominal rigidity, number 1. They have abdominal guarding. They are number 1. They have rebound tenderness, right? They have diffuse tenderness. If you see this in prioritization, it's a clue telling you that this is peritonitis. That's all. It's not a big subject. Just recognize that this is a problem and you have to intervene. Okay? The next one was CVP, which is central venous pressure. Look, central venous pressure is the pressure, okay, is the pressure, this is the pressure in the vena cava. I'll draw it and see near the right atrium. So if this is your heart, it has 4 chambers. Your right atrium, right ventricle, left atrium, left ventricle. The vena cava come here like that. You have an inferior vena cava and then superior vena cava. The pressure here is the central venous pressure. That's all. So that's the central pressure in the vena cava near the right atrium. Right? So that's the pressure. Then you have to know the normal and abnormal. Usually the pressure is 0 to 8 millimeter per mercury. Right? That's the so anything that is higher. If I tell somebody CVP is 15, you know this is what. When you see this, think about fluid overloaded. And then write the signs and symptoms of fluid overloading. Periorbital edema, ascites, leg edema, right heart failure, those lung crackles, all of them are all signs of fluid overload. Another way they can trap you is JVD, is jugular vein distension. This one is a little bit different. You have to know a few things about it, right? The jugular vein distension is not the vena cava, but it's looking at just the jugular angle. The jugular, the pressure in the jugular is the jugular vein pressure itself, which is in your neck. But in what way you have to, the way they measure it is based on the sternal angle or right atrium angle, which is very, very important. If they give you a question, pay attention to it. If it's a sternal angle, then you're looking for 0 to 4 centimeter water. That's the pressure, right? 0 to 4. If it's the right atrium, you're looking for 6 to 8. So pay attention, depending on which one they give you. If they say we're measuring the JVD from the right atrium angle, we're looking for 6 and 8. When we're measuring the JVD towards the sternal angle, we're looking for 0 to 4. And anything greater than 4 is high JVD. Anything greater than 8 in terms of the right atrium is high JVD. And then you can treat it the same way as fluid overloaded in this situation, and you can manage the patient in terms of fluid overloading. That's all. And that is the concept I want to pass on. The next one It's one of my favorite. It's Bell palsy and trigeminal neuralgia. What is the difference? They are cranial nerve problem. Bell palsy is cranial nerve 7, right? Which is a facial nerve, right? And these are motor and sensation, right? Yes, motor and sensation of your mouth, but mostly motor of your face. Once again, motor of your face and sensation of your mouth. So mouth, and this is face. That's all. What happened? Presentation is usually acute onset. It's one side, unilateral. Sometimes associated with the viral hernias. You see the word, or sometimes idiopathic. Most of them, we don't know what happened to you, right? And what does the facial nerve do? Facial nerve is for muscle in your face movement. Therefore, you can move that side of the face. That's all. You're going to draw on that side. You can have droop, facial droop. Your smile is asymmetrical, right? You cannot close your eyes because your muscle is involved in closing your eyes. So you won't be able to close your eyes. You can't close your eyes. So can't close your eyes. Right? So those are the signs and symptoms the patient is going to show. When they frown, they can't. They cannot frown their face. Right? Smile is bad. Right? Because of that, you have to teach them certain things. The sensation of their mouth will be affected by the sensation of their face is intact. Okay, that's very important. So what do you teach them? Well, I know you're drilling, so chew on unaffected side. You need an oral hygiene, good one. Some Bristol toothbrush, right? Because you can't close your eyes, I need to protect your eyes, so you wear eyeglasses during the day and patch at night. But you cannot have tears, so artificial tears. The facial nerve control making tears, so you can dry your eyes. So you need artificial tears to do that. Of course, they will need steroid because it's inflammation, sometimes antiviral, right? That is what because of the viral effect, and then education that this can last for about 6 months. The key thing you need to know is there is no motor effect related to the body. So their legs, hands, okay. There's no pronator drift anywhere. So it's not stroke. This is what I'm trying to show you. It's not stroke. So they're not going to have anybody left, right. No, it's just the face. And it's only one face that is affected. Okay. Trigeminal neuralgia. This is cranial nerve 5. Its main function is sensation. Therefore, if it's affected, sometimes also by viral symptoms, acute onset, and it's unilateral. What are you going to see? Keywords. You're going to have throbbing in your face. You're going to have shooting in your face. You're going to have some electric shock. All this is done to confuse you, stabbing. You want to pick it apartization is all normal. Stabbing in your face when you rub your face or chew on that side or yawn or brush your teeth. Right? That's all. Teaching. before that, there is no sensory problem, no sensory issue. You can front your face is symmetrical. It's just painful when you touch it. So that's the key. So the treatment is chew on unaffected side. You also need oral hygiene. Use some Bristol toothbrush. All these things is very important. The medication for this is multimodal. That means you can use NSAID, you can use acetaminophen, you can use TCA, tricyclic antidepressant, right? You can use it. You can use even SSRI, but number one is a carbamazepine, which is an anti-epileptic, which can be used as a mood disorder. It can be used as mood disorder. So those medication can be used as a mood disorder. The problem is number one side effect is agranulocytosis, which can lead to what? Infection, sepsis. So if you have trigeminal neuralgia, I give you carbamazepine and you have fever, then I know I got to stop it because you can develop agranulocytosis. Remember, there's a medication called clozapine, which is also causes agranulocytosis, but they are different. This is antipsychotic. Carbamazepine is anti-epileptic. And this is the way you teach the patient. This is the management of trigeminal neuralgia, and that's the management of Bell palsy. The two difference, and you can find the difference between them easily. Almost done. Next one, cholecystitis and cholelithiasis. So your liver is here like that. Below there's a gallbladder sitting here. These are stones in them. And that is what we mean by, we call cholelithiasis. It's stone in the gallbladder. Gallbladder just stores bile so that when you eat fatty food, it can give it to you. You release the bile for fat digestion. Unfortunately, the gallbladder has different content. There's fat, there's acid. When the concentration changes, you form stone, like you form kidney stone. So which people are very good in forming stone, right? It's usually a female who is fertile, has a lot of baby, they are in their 40s, right? So they are in their 40s, or I would say 50s, right? Or maybe 40s. They're a little bit obese, right? So those are the key features. And those are the one you have to pay attention to. And then, so they are female, fertile, they are in their 40s, and they're in the obese, and they stay on fatty food. These are risk factor for stone, cholelithiasis. This is lithiasis, lithiasis. That's what I mean, making stone. When the stone block the tube and you get inflamed, you get cystitis. So you get cholecystitis. This is inflammation of the gallbladder. So it's inflammation of the gallbladder. Therefore, if it's an inflammation, they're going to have fever. White count will be elevated. Heart rate will go up. They're going to have pain. But where is the pain? Right upper quadrant. What is the characteristic of the pain? Right upper quadrant radiating to the right shoulder. So radiating to the right shoulder. Those are the key that you will see about this patient. Their white count will be elevated. So this is classic symptoms, right? They may have nausea. They may vomit. This is all expected, right? What is your treatment? Well, your treatment, NPO, you already vomit, antiemetic, right? IV fluid, pain management, antibiotic, right? Prepare for surgery. They don't need the NG tube unless they're vomiting a lot. And most of the time, they don't need too much. The surgery is laparoscopic cholecystectomy, removal of the gallbladder. They go home following day, and then they will need instructions, right? Instruction, no bath for 6 weeks. They can take shower, right? They have a glue that will comes out on its own, right? These are the things you teach these patients to pay attention to. They can resume activities as tolerated, right? That's all. And that's what you teach them. Is there any priority things you have to worry about this? No. Cholecystitis with a white count of 20,000. No, unless they have peritonitis, you don't need to worry about anything about them. Okay. And the last group on the list is the neurological problem. Yeah. First one, myasthenia gravis. Look, for neural problem, most of them are autoimmune. And what is the problem? This is a acetylcholine receptor, right? You have acetylcholine receptor here, and there's a muscle here. The muscle and the neuron talk through the acetylcholine receptor. Acetylcholine receptor come and bind here like that. So it bind to the receptor here, and then make the muscle contract. Unfortunately, in myasthenia gravis is an antibody that block this receptor. So it bind here. When it bind to the receptor, it does not work. It does not allow the muscle to contract. That's all. That is the problem. So you have antibodies making against acetylcholine receptors. So what is the key feature? Every muscle is affected. Which are the key muscles? The vulva and the eye muscle. That means the swallowing muscle and the eye muscles. So what do you see in this patient? They're strong in the morning, weak at night. That is the key. So as the day go by, they get weaker and weaker and weaker. So we expect severe weakness at night. It's suspected, or in the afternoon. So what do? Treatment. Take your medication in the morning. Do your physical PE, physical activity in AM. Anything that needing to be done should be in the morning because that's when they're strong. What is the treatment? Give them more acetylcholine. How do you do that? You give them stigmin. I call them stigmin. So you have neostigmin or physiostigmin. These are the medication that will increase your acetylcholine. The problem is if you increase your acetylcholine, you're creating more cholinergic state. So if you go up too much, you have too much acetylcholine. So too much, the patient will have excessive what? It's acetylcholine. So cholinergic, excessive, you have drooling, right? Salivation, you have diarrhea, you have urination, you have pupillary constriction. All this is there. Too much cholinergic effect. So this is the side effect of that medication. When you give them to them too much, you overshoot. So pay attention. It's different from myasthenia gravis crisis. That means myasthenia gravis gravis crisis is the original. That means the weak, severe weakness from the acetylcholine cannot bind. So it's the initial symptoms, but it's the worst. Cholinergic crisis, you treating them, but you give them too much cholinergic, and that's all. The other treatment you need to teach them is what? Avoid some triggers like surgery. Surgery can do that. Infection, medication can do that. Make sure you get your immunization. All of this is important. What is the priority for myasthenia gravis? You can have severe weakness during the night. I don't care. Number one, if you slur your speech, if you have dysarthria, if you have what? Dysphagia, these are all B-sharp moments that you have to like say something. Patient is you have to intervene. So when you see that, intervene. That's the priority function for that. Okay. Now, his other friend is what? Multiple sclerosis. Multiple sclerosis is difficult to diagnose. If this is the neuron, it has nothing to do with the muscle. It doesn't care about the muscle. This is usually what's the neuron. We have something we call myelin. And these allow signals to jump. In multiple sclerosis, there's no myelin. So there is the myelin is like that. So signals cannot jump. They can just roll slowly, 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 slowly. It takes forever. That's all. So it's also an autoimmune problem. So it's also an autoimmune problem. So multiple sclerosis. This is also an autoimmune problem. But it's a demyelination issue. So the biggest problem associated with multiple sclerosis is difficulty diagnosing it. In the case form, it's very confusing, but the key word to distinguish between them is multiple symptoms or cluster of symptoms, because they have relapsing and remitting. This is it. She came in 2 months ago. She has this. 6 months ago, happy. A year ago, this happened. 4 months ago. That is what the case will tell you. You say, oh, why is these patients multiple? And then they will see they have depression. That's your clue. They have weakness, then it stop. It come back 2 months, 3 months. That is the key for the diagnosis of multiple sclerosis. It's not an easy one, but it goes all over the place. That is your buzzword, and that is your treatment. Treatment, avoid triggers as much as possible, right? I want you to get your immunization. They will need some steroids. They will need immunomodulator, like acetylcholine, hydroxychloroquine, therefore neutropenic. Precaution. You know all this thing. I'm just guiding you key things you are supposed to know for this. Neutropenic precaution when you're talking about them. Look, these people, because of their multiple complaints, they have depression, take care of it. They have bladder issue, take care of it. They have a bowel problem, take care of it. right? They have spasm, take care of it, right? All of this thing is multiple. They have sensation issue. You tell them don't put any hot or cold stuff on your skin because you're going to burn yourself. You have to manage all these problems. What is the priority? Once again, slurred speech, dysarthria, dysphagia. Remember though, slurred speech can be normal in multiple sclerosis, so I'll focus more on dysarthria and dysphagia or problem swallowing. Those are the priority for that condition. The next one is GBS. It's also a demyelination, Guillain-Barré syndrome. So look, this one is the easiest of all. They cannot give you a question that they will, it's GBS and never tell you this. Patient will have upper respiratory infection or GI symptoms. All of a sudden, and this will happen like a week later, all of a sudden, they have ascending paralysis. That's all. That's the buzzword, and the rest is history. Ascending paralysis means your leg was heading, so you have ankle weakness, leg weakness, then the rest of the body, your hand, then your airway, then you die. So these are the progression. So that's why we call it ascending paralysis. You do the same thing. They're going to be weak. They're going to have spasm. They're going to have sensation problem, not a priority. What is your number one? Protect your airway. Therefore, what is your priority? If they have slurred speech, airway issue, dysphagia, swallowing problem, that's the thing. Teaching, you tell them vaccination does not prevent this. They can have recurrence, so they should let doctor know if they have URI symptoms or GI symptoms. They should let the doctor know. Family members are not protected. And they don't, there's no test, no genetic testing to look for Guillain-Barré syndrome, right? They don't have to do that, right? It's not also infectious, it's not infectious. So these are the things you tell them. And the last one, ALS, amyotrophic lateral sclerosis. This is also like Guillain-Barré syndrome, but involves the spinal cord and the brain, and all the muscles are involved. You cannot just mix this with GBS. There is no ascending paralysis. It's just the whole body is weak and sensation is affected. They can't do anything. They have a bladder issue, they have a bowel, they have respiratory, they have GI. They can't do anything. So they may need tracheostomy, they may need feeding tube, they may need anything. It's not a priority. Number one is airway, same thing. So look for dysarthria, dysphagia, slurred speech. They just know you have to take care of their other non-medical problem, all the things that they will complain about. There is a medication that you can give them, Riluzole. It does not cure, that give them 6 months to live. And this is adaptant class. I've covered everything I told you we need to cover. This is